Good morning, everyone. My name is Rob Mullins. I'm a professor at the University of Iowa. It's a real pleasure both to get to participate in this meeting today, and I've been learning a lot from this great meeting, and also to have a chance to present some information to you about some of the structural and anatomical changes that occur in human eyes with macular degeneration. I have no financial disclosures that are relevant to this talk or any other talk. And this one there. Oh, yes. So just to give you a brief summary about what I'm planning on speaking about this morning, I'm going to talk about histological methods as kind of an overview very briefly, the use of human donor eyes for research, and then we'll move on to Bruch's membrane and its deposits, dry AMD and wet AMD, and then some of the histopathological changes that we observe in the choroid. So I'm very easily entertained and amused and everything. And, ever since I was a kid, I've always enjoyed these kinds of pictures where you look at this image here, and here's a gentleman, maybe a cavalry officer or something. He has a nice hat, he has a nice mustache. But if we flip this image upside down, we see something very different. We see the officer's horse instead of the officer himself. And so depending on how you look at these images, you see something very different, and there are different ways to approach imaging data. Now, this is also true in the retina, and the image on the left is the sort of histological clinical view that people are used to in journals. And the image on the right is more familiar maybe to people who publish in a lot of basic science journals. So on the left, the photoreceptors are pointing down like stalactites, and on the right, they're pointing up like stalagmites. And I apologize, it looks like my slides are going to continue to wrestle with me to advance before I'm ready for them to do that. So you'll always get a little sneak peek of what the next slide is if I'm unable to intervene in time. So, even Cajal in his original publication of the retinal structure, he showed the photoreceptors pointing up in these beautiful silver impregnation studies that he did. And so basic scientists have often followed this kind of example and have always oriented the photoreceptors up. We always sort of thought we should really put the photoreceptors on their side, sort of pointing to the side, because if a patient's sitting with their chin in the slit lamp chin rest, really the clinician is looking at the back of the retina in that way. But, certainly since the advent of OCT and its popular use and its popular use in research, everybody's kind of getting used to, or most people are getting used to this idea that the most familiar way to orient the retina is the photoreceptors pointing down. And that's the way that I'll show you all these images in today's talk, where the inner retina is on top and the outer retina is on the bottom. So all of the images I'm going to show you today are from human donor eyes. Clearly, there are a lot of challenges in collecting and using eyes for research, and the advantage of these samples for the talk I'm giving today is we're really interested in what exactly is happening in the macula of human eyes with macular degeneration. And so everything I'll be showing you today comes from a human eye collection at the Institute for Vision Research. There are a number of ways that one can use histological information. And what I'm trying to show in this image is that as you go through sort of more aggressive processing, you're able to see greater detail in many cases, but you may lose tissue biochemistry. So as we go from sort of unfixed cryosections all the way over to thin sections embedded in resin, we typically extract a lot of the biochemical data, but we preserve a lot of the anatomical data. And so you have to sort of decide where on the spectrum you want to be. Now, the advantage of dehydration and sucking the water out of a sample and replacing that water with a hard substance like resin, like EPON, is it allows you to collect very thin sections that allow you to get very powerful levels of resolution by allowing electron streams to pass through and be interrupted only where there's electron-dense material. So, clearly dehydrating and replacing tissue water with other substances has advantages. On the negative side, you can lose a lot of the molecules that you may want to be studying. So in this pair on the bottom, on the left-hand side is a fixed tissue section that was infiltrated in sucrose and OCT, and we collected frozen sections. On the right is a piece of the RPE and choroid from the same eye, but it was processed in paraffin. And you can see if we use a stain like Sudan Black B that shows up in blue here, we completely extract that Sudan Black B staining material in the paraffin section. A couple of other considerations for immunohistochemistry. These have been brought up both in Dr. Hollyfield's and Dr. Duncan's talk earlier. If I brought you this image and said, hey, look at this labeling, what do you think? At least for some of my partners, they'd say, oh, this is fantastic. Look at that really specific and beautiful labeling of the retinal pigment epithelium. And I said, well, wait a minute, that was the secondary control. What really you're supposed to see is this green fluorescence on the right. And so RPE, as we have heard, accumulates autofluorescent compounds during the course of normal aging. And you can see these here from 1 year of age to 88 years, that whether you're looking at the TRITC channel, FITC channel, or UV, there's an age-related accumulation of autofluorescent material in the RPE, and in the case of the UV channel, in Bruch's membrane. So when you're doing fluorescent studies on RPE, this is always going to be sort of a challenge. There are a few ways around this. You can use a long wavelength fluorophore that that's not excited in the same wavelengths as RPE lipofuscin. You can also quench with a compound like Sudan Black B or True Black that just removes that autofluorescent signal. Anyway, these are some things to be aware of. One other thing I wanted to make sure that I shouted out to is, when you're interested in the histopathology of AMD, there's this beautiful website, projectmacula.org, that was put together by Kristen Curcio. This is freely available to anybody on the planet that has a computer. And in many cases, these very high resolution, high quality histological images have corresponding OCT. So you can actually see from an OCT image that the clinician took to the very well-preserved histology. So it's really a fantastic resource. I'd recommend everybody check it out. All right, well, talking about wet and dry macular degeneration, you know, Ricky Bobby, I think, put it best in the racing world when he said, if you ain't first, you're last. And in the case of AMD, if you ain't wet, you're dry, okay? So basically in AMD, everything that's not wet AMD is dry AMD. So early AMD, intermediate AMD, geographic atrophy, these are all forms of dry AMD. Once you have new blood vessels, this is now called wet AMD. Many individuals will go through their life with normal aging changes and won't develop any of the sequelae of macular degeneration. Many patients will convert to early AMD, develop drusen and some pigmentation changes, and will just keep that early AMD through their lifetime. And so we'll talk a little bit about the histopathology of early and intermediate AMD and Bruch's membrane deposits. So again, just to sort of define these different categories, there's early and intermediate AMD, in which there are Bruch's membrane deposits and RPE changes that Dr. Duncan talked about earlier. Advanced AMD that can either be in the form of advanced dry AMD, which is atrophy of the pigment epithelium, or advanced wet AMD, which is the new growth of blood vessels into the retina, or subretinal or sub-RPE space. We'll talk about that a little bit more shortly. So Bruch's membrane, as we've heard earlier in today from some of the earlier excellent presentations, is a multi-layered extracellular matrix compartment. And on the left here, you see an H&E section showing the same sort of zone that's been zoomed in on the right. And you can see on the top here, the retinal pigment epithelium, here's the choroid capillaris, here's a pericyte, and then Bruch's membrane is this intervening extracellular matrix material. And here's just another view that's kind of similar. Oops. Sorry, that shows an RPE cell. Here's the RPE basal lamina. So the RPE here and the choroid capillaris here both have typical basal laminae. So they have collagen type 4, laminin, intactin, nitrogen, heparan sulfate, proteoglycan. Just like any other cell that forms a layer, these cells will form a sheet under them that they grow on, that they rest on, and that's a growth factor repository, etc. And in Hogan's original description of Brooks membrane, he includes all of these layers from the RPE basal lamina to the choriocapillaris basal lamina. And Dr. Curcio and the Sarkses both prefer this kind of nomenclature where Brooks membrane doesn't really include the basal laminae shown here. It's this intervening extracellular matrix material, including a layer of collagen. And here's this fibrillar collagen, these little rods and lines. Another layer of collagen here. These are called the inner and outer collagenous zone, and a layer of elastin, this very hydrophobic, stretchy protein in between the two layers of collagen. As Dr. Duncan called it earlier, an elastin sandwich. I'm going to steal that for future use. During aging, as Dr. Hollyfield mentioned, Brooks membrane undergoes some changing that can occur in normal aging. And these include things like a loss of hydraulic conductivity. If you try to pump water across Brooks membrane, you can pump it more with less force in a young Brooks membrane than an older Brooks membrane. It becomes calcified, it thickens, accumulates lipids, accumulates complement components, and accumulates deposits. And these deposits are really the sort of interesting feature that we can see clinically, and that are especially interesting in the case of macular degeneration. So Brooks membrane deposits can take on multiple forms, including what are called hard drusen, what are called soft drusen, calcified or regressing drusen, in addition to some sort of less lumpy, less discrete forms of deposit. You can also have these flat forms of deposit called basal laminar deposit, basal linear deposit, and of very recent interest from the work of Dr. Spade and Dr. Curcio is these reticular pseudodrusen or subretinal drusenoid deposits. And we've seen this excellent cartoon earlier. This is a summary of the different kinds of deposits that form in macular degeneration, which layers they form in. And so I just want to show a few examples of these. So here's a normal eye. This is actually me on the left and an eye donor on the right. And you can see the RPE, and it's sitting on Brooks membrane here. And Brooks membrane is this sort of soft pink structure that has these plunging intercapillary pillars. Hopefully you can see those a little bit. And so the RPE is just adjacent to Brooks membrane with no intervening material. Well, in early AMD, you can have what are called hard drusen, and you see these on the left here. And they're these relatively discrete, smallish spots, yellow or white spots that form under the RPE. And you can see an example of these on the right. These are sometimes called hyaline structures because they have this very uniform H&E appearance. And they're characteristic of normal aging, although a lot of them, folks that have a lot of them, it's often indicative of early macular degeneration. And again, these are small and they have sharp borders. There are also drusen called soft drusen. So there's a hard druse shown here on the left. You see again, it's a sort of hemispherical hyaline structure. And over here on the right, here's Brooks membrane again. And there's this very big wavy sort of heterogeneous material. It also stains with eosin, but it doesn't have this sort of smooth hyaline sheen, and instead it's composed of little particles. But most importantly, clinically, there aren't really discrete edges. And when you think about it, if you have RPE cells that are mounded over a drusen deposit, and the clinician is looking down, they're looking down through a lot of RPE pigment on their way to Brooks membrane. Whereas in this situation on the right, where the edges of the deposit are sloped, it's sort of more linear, there's not a really sharp demarcation. And that gives these more soft drusen clinical features. In addition, it's worth pointing out that in a lot of cases, what we see clinically as soft drusen, especially in the macula, are detachments of thickened material that I'll talk about in a second underneath the RPE. So a lot of times these detachments look sort of empty. Now, Christine has done some beautiful staining that preserves material in these deposits, shows there's lipid material that resides in there. In most histological preparations, these will just look like little domed detachments of the RPE with this thickened material underneath it. So there's been a lot of interest in what drusen are comprised of, both histological studies as well as biochemical studies that Dr. Hollyfield and Dr. Crabb and Dr. Nandapti have participated in. And I wanted to just sort of summarize many studies with one slide here. So drusen are largely comprised of lipids, esterified and non-esterified cholesterol, and that's approaching half of the mass from Christine's work. In addition, there are glycoproteins that build up in drusen, and these include proteins in the complement system, MHC antigens. This seems really important. We haven't really given it enough thought, I think, but you can find HLA-DR molecules within drusen. Apolipoproteins, especially ApoE, TIMP3 from the work of Dr. Anand Apte and others, as well as vitronectin and clusterin, inhibitors of the complement system. And on the right, we just see some immunofluorescent images depicting what this labeling can look like. One thing that is worth being aware of is that drusen can also have substructure. So while in many cases we see these hard hyaline drusen, you don't really see much variability from the top to the bottom. In some cases you do. And maybe the most striking of these is drusen that don't form in normal macular degeneration, but the ones that form in MALAT11 due to a mutation in the EFEMP1 or fibulin 3 gene, in which the material in the drusen forms in these sort of concentric onion skin type of layers, where you can imagine that the RPE is laying these down sequentially and building up these mounds, sort of like tree rings or something. It's very interesting. In addition, drusen can have what we call core domains, in which there's this little kernel inside of the drusen, which it's tempting to think is an early stage in the development of drusen, and that the material that's laid down subsequently is put down around that core. And these are really remarkable when you take tissue sections, treat them with the enzyme neuraminidase to remove sialic acids, and then stain with peanut agglutinin, which normally doesn't react with drusen at all. But when you've removed sialic acid first, you can often see these little core domains here. These are frequently ensheathed in MHC class 2 antigens, HLA-DR. And then you just see them merge on the bottom right there. The other kind of substructure that's been gaining a lot of interest lately is the presence of calcium inclusions in drusen. And this has especially been advanced by the work of Imre Lengyel and his colleagues, who have identified hydroxyapatite both in drusen and also in Bruch's membrane prior to the formation of drusen. So there's a lot of interest in this notion that mineralization of Bruch's membrane may be an early stage in the development of AMD. And I cite one paper here on the slide, but it's a active body of work right now. Well, in addition to those moundy kind of drusen, we can also see linear material beneath the RPE. So again, if you took all of this stuff under the RPE, between the RPE and Bruch's membrane here, and sort of piled it up, this would be an enormous drusen. Instead, it's been smoothed out into this basal laminar deposit. This has been described as the histological definition of age-related macular degeneration. So if you're not really sure how to categorize an eye, if it's got this thick, confluent basal laminar deposit, that's considered legitimate by many histologists that this is an eye with macular disease, macular degeneration. Ultrastructurally, these basal laminar deposits are really interesting. They form these sort of railroad track types of periodicity with dark staining and light staining alternating bands on transmission in EM. And this is reminiscent of what's seen in other tissues called long spacing collagen, which is can be generated by proteolytic degradation and reassembly of extracellular matrix molecules, especially collagen type 6. And then we also have a form called basal linear deposit, or BLIND, and this is lipidic material. So the basal laminar deposit seem to be more proteinaceous. The basal linear deposit is these lipid inclusions, membranous debris underneath the pigment epithelium. They can both form in these bands, and the detachment of basal laminar deposit, basal linear deposit is characteristic of macular soft drusen. And again, here's an image that I showed you earlier. This is this basal laminar deposit material that's detached from Bruch's membrane. Clinically, this would look like drusen from fundoscopic appearance, or OCT. And then most recently, there's this description by Christian Curcio and Rick Spade of material called reticular pseudodrusen or subretinal drusenoid deposits. In the original AREDs, these were scored as soft drusen, and really there was a fair amount of controversy when these were first described because the OCT imaging wasn't quite all there yet. Now there's not so much controversy that these this is material that forms not beneath the RPE, between the RPE and Bruch's membrane. It forms on top of the RPE, between the RPE and photoreceptors. So, I mentioned that usually AMD, most patients with early or intermediate AMD do not advance. And Jackie mentioned this in her talk as well. In some cases, patients will advance to a form of advanced dry AMD called geographic atrophy. And here's the clinical appearance of geographic atrophy. You can see these big soft drusen around here in the macula. But then there's some missing color here in this zone in the macula. And it's centered on the fovea in this case. And you see that the normal sort of orangish color of the retina is missing, and you're seeing almost into bare sclera. And this is due to, this clinical appearance is due to the degeneration of the retinal pigment epithelium. And here's what this looks like histologically. You can see Bruch's membrane is here, and here's the ganglion cell layer, and here's the internuclear layer, right? But the outer nuclear layer has almost completely degenerated, and you just see a little bit of this eosinophilic glial material where the photoreceptors are supposed to be. So this is the sort of clinical and histological appearance of GA. So in geographic atrophy, compared to a normal eye on the left, there's loss of the RPE, there's loss of the cornea capillaris, there's loss of photoreceptors. You'll see this in other advanced forms of macular degeneration as well. But you don't see much additional material in or beneath the retina. So it's really, we call it atrophy, of course. It's material is missing. Photoreceptors are missing, RPE is missing, cornea capillaris degenerates. And in that sense, it's a little similar to a disease like retinitis pigmentosa, shown here on the left. The big difference being that in retinitis pigmentosa, the RPE is preserved longer than it is in geographic atrophy. So one other histological feature that's observed in geographic atrophy, we also see it in eyes with choroidal neovascularization, is the presence of these structures called tubulations. And so you're looking along in the tissue section, you see these circles. Like, oh, is that a blood vessel? Those look like circles. No, this is material that's sitting in the outer retina at the level of the outer nuclear layer. And these were described in a RD book in 1997. So when you're having the opportunity to write a chapter for those RD books, and now they're even online, which is even better, make sure you take advantage of that, because it's a great opportunity to put some cool data. And Dr. Hollyfield, Dr. Rayborn published this study about tubulations in the outer retina of macular degeneration patients. We used to call them rosettes, now we call them tubulations, as we have a little bit better 2D view or XY view of the retina, what they look like on OCT. And here's another image of these tubulations. And you can see, if you look like here and here and here, you see inner segments of photoreceptor cells, of cones. So there are still preserved cone photoreceptors that line these tubulations. You look over at this one, you can even see some what looks like outer segment material kind of piling up in the center of that tubulation. When you see a structure like this, this is a consequence of what my colleagues Ed Stone and Ian Hahn referred to as death from below. So in a disease where there's a primary photoreceptor degeneration, you don't see this. This happens when there's something in the supportive structures of the retina, like the RPE and the cornea capillaris, that degenerates, and then the surviving photoreceptors sort of circle the wagons and form these structures. And if you label with peanut agglutinin, which Dr. Hollyfield earlier in his talk showed us the labeling of cone photoreceptor outer segments with this lectin, you see that the tubulations are actually full of PNA binding material. So they're still viable cones. They're still making outer segment material in these bizarre reorganized outer retinas. One thing structurally about the outer retina, as you know, is that there's an external limiting membrane. It's not really the external limit of the retina, because the photoreceptor inner and outer segments go past, as well as the RPE. But it's the layer of where the Mueller cells send their end feet and form these junctional complexes. And this is just an example on the right here of sort of, if you look at it on FOSS, there's this honeycomb pattern where the photoreceptor cells poke out their inner segments. And in what's called incipient geographic atrophy, you can see disruption of the external limiting membrane. So here's a normal eye. You can see this red ICAM1 labeling of the external limiting membrane. This is actually an eye with X-linked retinoschisis, so it's not incipient GA, but it shows you what this looks like, where there's interruption of the external limiting membrane. And this is a feature that's been recently described in association with areas of retina that are going to undergo atrophy and GA. Lastly, I just want to touch on this briefly, and I'm going to talk a little bit more about the choroid than I do about the RPE. But there are certainly changes in the RPE. These are more remarkable in advanced disease than early disease. You can see on the left here, this is a sort of normal looking RPE mosaic. There are a few things that are strange about it though. One is that the autofluorescence of the RPE that is normally red and green when you stimulate it this way, some of the cells have these blue autofluorescent profiles. I don't understand it. Maybe somebody can tell me what that is during the Q&A part. The other thing that's interesting here in this eye with geographic atrophy is there's normal RPE over here, and you see these sort of hexagonal patterns that convert into this kind of mashed potato-y kind of undefined epithelium on the right. And in addition, you see some little window defects, areas where there's actually missing RPE cells. Again, I want to point out that Dr. Curcio's paper on this, recent paper, describes a variety of phenotypes of RPE alterations that happen in advanced AMD. And this includes things like these migrating RPE cells that can leave the Brooks membrane and migrate up into the retina. So in addition to just staying a normal eye or converting to early AMD or converting to GA, a subset of eyes will develop neovascular membranes. And so we'll talk next about the histopathology of those. As Dr. Duncan mentioned in her talk, there are really sort of three categories that have been described of neovascularization. Type 1, which is sub-RPE, used to be called occult. Type 2, which is classic CMV, which used to be called classic, or I guess that's obvious because I just said that. And also type 3 CMV, which is these retinal angiomatous proliferations and that actually form from the retina. So this is the right and left eye of the same individual. And on the left here, you can see here's Brooks membrane indicated by the arrows. And here's the RPE. And if you look at this, you might almost say that looks pretty normal. If you weren't paying attention to these arrows, you might say there's the RPE, there's Brooks membrane, looks pretty okay. But all of this material between the RPE and Brooks membrane is abnormal. That's all in neovascular membrane. But these type 1 CMDMs can be a little bit subtle. On the right, nobody would say this is normal, right? A fourth grader could tell that this isn't a normal retina. And there's this fibrosis underneath the retina. Here's a tubulation. The photoreceptors are all dead. There's a little bit more fibrosis under here. The RPE, this is what Christine calls entombed RPE cells, which is kind of cool as we're getting ready for Halloween. And the difference is where the membrane is localized, because in this case, there's neovascular growth on top of the RPE, and in this case, it's all beneath it. And so the right and left eye from the same individual, in this case, have these two different forms of neovascular membranes. Like geographic atrophy, in CMV, there's loss of RPE, there's loss of choriocapillaris, there's loss of photoreceptors, but it's common to see additional material that doesn't belong in a normal retina. As you're going through and sort of enumerating the layers of the retina, there shouldn't be this fibrotic stuff above Brooks membrane. We don't know a lot about this. It's not common. Occasionally, it looks like drusen can be sort of a substrate for neovascular membrane invasion. So whether Brooks membrane is sort of weakened or loosened up underneath drusen, or the loss of our choriocapillaris under drusen signals them to grow in, but it's an occasional observation. So some of these images that I'm showing you use the lectin UEA1 that reacts with fucose sugars. These are present on all endothelial cells in the eye. And this is just, it gives you a picture of here's the RPE and here's Brooks membrane. And Brooks membrane has been cracked in the middle with invasion of these neovascular endothelial cells. And you can also see, if you look for where normal choriocapillaris should reside, like maybe there's a normal choriocapillaris vessel, maybe. And there's nothing here. This is a big vessel that's kind of drifted up from lower levels of choroid. So it's very common to see loss of choriocapillaris in eyes with neovascular membranes. These neovascular membranes can be huge. This one's at least 0.5 millimeter tall, or they can be really subtle. And if you look at an H&E section like this, it may not be that obvious that there's a neovascular membrane here. There's this very small, shallow type 1 CMDM in the eye. And you look at the photoreceptors, they look pretty okay, so it's not always associated with vision loss or photoreceptor death. On the other hand, one of the worst things that can happen is you can have subretinal fibrosis. This is replacement of the exquisitely organized neural tissue of the retina with connective tissue, right? And so this is mostly, I think, type 1 collagen. It's not compatible with good vision. And so understanding what converts normal retina to fibrosis when you have a CMDM is something that would be really useful to know. All right, well, I want to talk a little bit in my remaining time about some of the new insights from histopathology of macular degeneration. And, most of the focus has been on RPE in the history of studying this disease. There have been histological studies that suggested that something was different in choroid, but these histological studies have been inconsistent. So some studies found increased choriocapillaris in macular degeneration, some found decreased choriocapillaris. And this is owing in part to the fact that all of these studies were performed using hematoxylin eosin stain and not using a vital stain for endothelial cells. Briefly, there are some known vascular changes that occur in the aging choroid. These include thinning, dropout of vasculature. From Jerry's lab, there are mast cells that accumulate. Jerry Letty's lab, there are mast cells that accumulate around Brooks membrane, especially in geographic atrophy. There are some molecular changes, including membrane attack complex accumulation, C-reactive protein, changes in gene expression. And so choroid, a lot's going on there that hasn't been fully appreciated until fairly recently. We know that in normal aging, the choroidal thickness decreases, and it decreases at a rate of about 2 to 3 microns per year. This is also true in donor eyes. If we measure the choroid in young versus old eyes, we see a loss of choroidal thickness. And a few years ago, there was very little interest in this area of choroidal thickness. So this is PubMed citations over time. You can see nobody cared back in the early 2000s. And then Rick Spade came along, started doing enhanced depth imaging OCT, and look at this, takeoff. So, with all of this increase in papers on choroidal thickness, if nothing is done to stop this trend, soon all of the papers will be choroidal thickness papers in the whole biomedical literature. So, but anyway, we're not doing our part to stop that because we're very interested in this topic. And geographic atrophy eyes have reduced choroidal thickness. So the big, thick, highly perfused choroid that Dr. Hollyfield told us about in the submacular area undergoes thinning in eyes with geographic atrophy. Histopathologically, we've done some work to characterize what's happening at the level of choriocapillaris with respect to drusen and ghost vessels, and I'll tell you about those in a second. And what we saw is that you lose choriocapillaris as you increase abundance of drusen. And so as drusen increases on the x-axis, choriocapillaris perfusion area decreases. RPE doesn't change very much, at least if we're using height as a measurement. That's probably the wrong measurement, and you can tell me why in the chat. And the other thing that was kind of remarkable in this study is that the more drusen an eye had, the more of these missing choriocapillaris vessels there were. Right? So again, here's the UEA labeling of normal choriocapillaris through here, but here underneath this druse, there's a missing vessel. You still see a lumen, but there's no red lining to it. And same thing here. We can see ghost vessels on EM, and eventually these will sort of fill up with collagen. They'll sort of like it's a sedimenting stream or something. And here's the RPE, basal laminar deposit, basal linear deposit. The choriocapillaris pillar character supports membrane, but there's no endothelial cell where it belongs there. And then occasionally cells from vessels in the Sattler's or Haller's layer of, especially Sattler's layer of the eye will sort of drift up into the old choriocapillaris ghost area. Choriocapillaris density decreases as a function of early AMD, but it really decreases in geographic atrophy. And this loss of choriocapillaris and geographic atrophy happens outside of the areas of RPE loss. And so this is just an illustration of this. Here's a normal eye with the RPE, looks pretty beautiful there. There's this columnar monolayer. Here's the choriocapillaris. It's very intact, pretty confluent layer of capillaries. In geographic atrophy, outside of the lesion, I mean, this is not RPE that's going to win some beauty contest or something, but it still is an intact layer of RPE and with degenerated choriocapillaris beneath it. And a lot of the reason why this loss of choriocapillaris has been unappreciated is because if you look at an image like this or a similar H&E image, and you're counting blood vessel lumens, you'd say, oh, that's pretty interesting. That looks like pretty healthy choriocapillaris. There are 4 vessels, right? But if you use a vital label like UEA1, you see that of those 4 tubes in cross-section, only 1 of them is actually lined by viable endothelial cells. The other 3 are ghost vessels that still have a lumen, but that lumen's not going to allow blood flow through it. So in summary, we can see changes in early atrophic and neovascular AMD. These can be discriminated using routine histology. Again, I think it's very useful to sort of think of neovascular AMD as this accumulation of often scar tissue, with geographic atrophy is more a withering away of the normal tissue. And to really have a complete insight about the cell biology of these diseases, where we're quantifying things, requires additional methods like comparing viable endothelial cells with ghost vessels. So for future directions, there are a lot of things that one could think of. You can probably think of better questions here than I can. Certainly, what converts normal aging to AMD? So on that continuum, why do some eyes preserve normal Bruch's membrane and keep the RPE and choriocapillaris photoreceptors all still functioning well, and other maculas will undergo some of these very severe degenerative changes. And we know that genetics is part of the answer. We know that diet is part of the answer. At the cell biological level, what's going wrong that's making those cells get on the wrong path? And is that something that we can interrupt? Why do endothelial cells go rogue in neovascular AMD? Is it just VEGF signaling, or are there other factors? Is it enough to just break Bruch's membrane, or do the endothelial cells also have to be activated some way? With drusen, do genotypes affect the kind of drusen you have? Do certain genotypes associate more with the basal laminar deposit detachments? Are others involved more with the hard hyaline drusen? And what's this relate to, or how is this related to the composition of drusen? Are these cores important? Is the order that different molecules are laid down important? And if you could stop sort of the earlier deposition of one of these molecules, would that be enough to keep the RPE and the Bruch's membrane healthy? What are some factors that contribute to loss of Bruch's membrane integrity? Why does it get brittle and crack in aging? You know, it's not only in AMD that Bruch's membrane cracks lead to new blood vessels that are pathological, but we'll hear about animal models where this happens in the next talk. It happens in pseudoxanthoma elasticum. It happens in pathologic myopia in some cases. So it's not just AMD specific that a bad Bruch's membrane can give you neovascularization. Can you repair Bruch's membrane breaks? And as we'll hear about later in today's talks, what role do macrophages and microglia play in this transition? I have an abbreviated bibliography. Basically, read anything by Kristen Curcio, read anything by Jerry Letty. You'll be good. Here are some papers though that are related to the stuff we talked about today. And for a few take-home messages that we're asked to come up with, for pitfalls to avoid, do be aware of the retinal orientation. If you're asking a funding agency for $1 million grant award, don't label the ganglion cell layer as the outer nuclear layer, because this does not raise confidence in the histology. Also be aware of topography. This pair of images on the right here are the same eye at the same magnification. This one's from the macula, this one's from the far periphery. So where you are as you're writing papers and grants, be aware of that, because people will want to know. And as I mentioned earlier, autofluorescence is a challenge. There are some ways to get around that. I'd also say that quantitative studies are important. And when you do histology, you can kind of go and point that microscope anywhere you like in the field. And same with cell culture. You've got a field of cells. How are you going to decide which one to take? And, so having people that are doing the measuring who don't think that their livelihood depends on a certain outcome, and who aren't invested in terms of the paper, in terms of what they find, or don't even know, doing masked studies where somebody can measure or count something is really valuable to the field. So I encourage you to do that. And then the damage to the choriocapillaris is a feature of AMD that needs to be considered when people think about this disease. I think is also a take-home message. So I'd like to thank the organizers of this meeting. I'd like to thank the Bright Focus Foundation for putting it on. Again, I've been learning a lot of interesting stuff, and I hope you are too. Anytime we do research on donor eyes, I like to thank the eye donors and their families. These are members of our community who have decided to make this very private gift in order to advance research and advance our understanding. And all of the stuff that we know about the histopathology of this disease comes from the gift of these individuals. Always would like to thank our funding sources, NEI, and the folks in the lab who do all of the experiments. And I'd like to thank you for your attention. And at that point, I would like to do my best to answer any questions.
Thanks, Rob. Sorry, all this time and now I can't talk. I'm going to start with 2 questions from the virtual audience. The first is from Josh. Rob, what do you make of the PNA core in the drusen you showed? Do you think the core outer segment material could be a drusenitis?
Well, that's a very cool idea. Right. So as Josh says, the outer segment of cones is surrounded by this peanut agglutinin binding material. And it's been characterized by Joe Hollyfield and Greg Hegeman as to what the glycoproteins are that are present there. In some studies by Feeney Burns on monkey drusen, where animals were fed radioactive precursors and the material was studied of what ended up in drusen, they didn't find rhodopsin. And we don't see known molecules that are big outer segment components accumulating in drusen. Whether that's just because the epitopes are destroyed and that there may still be some of that material there, we don't really know. Certainly the RPE is called upon to destroy exactly 100% of all of this photoreceptor material every single day. And if the RPE gets a little imperfect, it doesn't need to be, it can still be awesome, but if it's imperfect, you're going to end up with undigested material that needs to go someplace. So I like that idea. We've never tried to look for things like chondroitin sulfate. Well, I don't think that's true. We've never seen chondroitin sulfate proteoglycans in drusen cores, but there may be some other proteinaceous component that's still there, that's represented by that GalMac disaccharide. So I like that idea, Josh.
Great, thank you. We'll take a question from the live audience.
Hi, Rebecca Pfeiffer from the University of Utah. This may be a naive question, but looking at your EM images, why are the lipid deposits electron lucent when osmium tetraoxide is so lipophilic?
So that's a great question. We do use osmium to preserve lipids as much as we can. There are more aggressive, fancy techniques that Christine Curcio has used to better preserve those lipids. Because even with osmium post-fixation, you can still lose a lot of the lipid material. So, but that's not a naive question. It's a good question. I don't know the answer other than that.
And one more question from the live audience.
My name is Kofi from the McGee Eye Institute, University of Oklahoma Health Science Center. My question is, are there any studies targeting the lipid synthesis and metabolic pathway on how it affects drusen accumulation? The second one would be citing an example from one of the studies called the ACCORD studies, looking at cardiovascular risk. Here they looked at phenofibrate on risk of cardiovascular diseases, but they did find that phenofibrate reduced the progression or the onset of diabetic retinopathy. And this drug is being used currently in Australia for the reducing the onset of diabetic retinopathy. Now, these drugs are shown to reduce hyperlipidemia or dyslipidemia. So the second question will be, is there any relation between patients that are taking drugs like phenofibrate or statins on drusen accumulation?
Yes, those are great questions. I'll answer the second one first, and then I know there are other people who are smarter to answer your first question. So, and there are probably people smarter to answer your second question too, but I'll take a stab at that. So for the lipid lowering concept for AMD, there are a lot of studies that, when we think about the risk factors, as Jackie mentioned earlier, smoking, high blood pressure, high body mass index, Western diet, all of these things are in different studies, more or less, except for smoking. All of these studies are more or less associated depending on the study population and how the experiment was done. And so there is, clearly some association there, but it's not like, it's not profoundly easy to study. And since all these studies are done on humans anyway, and surveys and things, it's difficult to really answer with a straightforward, concrete answer. For statins, Dimitrios Vavas did a study where he put some patients on high-dose statins and saw some drusen resolution. Drusen can stay, they can come, they can go. And from that study, it was very encouraging that Drusen may go. The dose was high, and I think we're still waiting to see some replication of that, but there is indication that, that statins could be beneficial there. For people interested in C-reactive protein and some of those biochemical events happening in the choroid, statins also lower C-reactive protein, which Joanna Seddon has shown is associated with increased risk and progression of AMD. So I think these things are definitely all interrelated, and there's still a lot more to learn about them.